Good evening, America. Thanks for being here. My name is Dr. Randy Fink, and it is time for Fertility with Fink. It is the place that we come every Tuesday evening at this time, live via internet. We are here from Pensacola, Florida tonight, where I am a fertility gynecologist at New Life Fertility. We also have offices in Dothan, Mobile, Alabama, Panama City, and we see folks from all over this great nation of ours. I am happy to consult with you anytime if I can be of service. How's it going tonight? Every Tuesday evening at 5 o'clock, we are here uh, which is 6 o'clock on the East Coast, 4 o'clock in the mountains, and 3 on the West. It's my favorite place to be all week long. How's it going? How was your weekend? It was a beautiful weekend here along the Gulf Coast. It's been a very nice couple of days. We had a little bit of rain kind of early Sunday morning, but it blew right through, and then everything was over and done. It's starting to get a little cooler outside, so we're enjoying a little bit of this thing that we call seasons here, which I never had in South Florida. Certainly had a bit in Colorado when I was there, but yep, it's a lovely place to be. Let's say hello to all of our friends. Good evening, Rosa. Thank you for being here. Savannah, how are you tonight? Oh, look who is here. Daisy is here in Miami. Thank you for being here, my friend. Hello, Styles family. Gradle, my mother, the Bama gal, and dad over in Mobile, Alabama, cavelling away. Nice to see you this evening, folks. Melissa, howdy. We've got Amber here, and we've got a couple of different feeds here. We've got Instagram, my Instagram, Randy Fink MD, which is right here. We've got LinkedIn and Facebook and YouTube in the middle. We've got New Life Fertility's Instagram over on this side. Throw your questions at me tonight, would you? Happy to answer those things and get us all on the same page, talking about fertility, talking about making families, talking about women's health and gynecology and obstetrics and all those things that are so interesting, things about girls and boys, birds and bees, and all that other good stuff. Let's see what else here. It's kind of been an eventful week going on, in the rest of the world. And while I try very much to stay clear from making political commentary, what I would love to say here is this, and that is that, think of think of what a place our country would be and our world would be if folks weren't so caught up in who gets the credit and who gets the blame. If we could all just focus on people helping people without being worried about who's getting the finger pointed at them or who's getting their back patted, just imagine what we could conceive if we were just people helping people. So that is my dream for our society. But unfortunately, I think what with partisan politics being what it is, it's much more about trying to make sure that the other guy doesn't get credit. But, take it out of politics, take it into your own life, take it into the workplace, take it into, but the problem is in the workplace, we're incentivized in order to work hard. So, we want and expect credit where credit is due, but just think of the possibilities if it weren't so much about having to prove who was doing it right, if we were all just working for the common goal. Man, what a place we would live in. And I try to embody that here at New Life Fertility. We're not this is really all about you. It's all about making your family and about making the right choices in order to be able to get there. And gosh, I find that a really kind of special place to be and a special environment in order to be able to work in. So Daisy, thank you for saying such nice things. Hi to the best doctor, she says. Melissa, so nice to see you. We've got Noodles and looks like Rice Ninja. We've got Plant Honeys, La Mujer, hello. Timmy, hello, Timmy, if Timmy is actually there. Timmy the kitty cat. I just sent a wave. Angela's here tonight, as is Beth and Faith, Hope, Love, Warrior Fertility. Thank you for being here. So Melissa says, FET, third FET next week, thoughts on an HCG wash. The first FET made it to about 6.5 weeks, and then the last FET wasn't successful, contemplating transferring two. Okay, so first of all, let's talk about the number of embryos to transfer. So I recommend that you go by the guidelines from the American Society for Reproductive Medicine. If you have a tested embryo, that is one for which you've done PGT testing, I would recommend you really only transfer one, because the odds of that embryo sticking are very, very high. If you have two of them, the odds of two of them sticking are very, very high. And really, when you look at the outcomes of pregnancies associated with IVF, IVF itself really does not harm pregnancies. Where the harm starts to come in is in the face of multiple embryo transfer, or in the place in the face of having multiple gestations, twins and triplets. Because when you have even twins, the risks associated with twins skyrocket compared to the risks associated with a singleton gestation. There is an extremely high risk of bad things happening, of preterm labor, preterm delivery, prolonged hospitalizations, prolonged NICU stays. There's an increased risk of birth defects. There's an increased risk of autism. There's an increased risk of lifelong problems associated with a multiple gestation. Now, the hard part there is almost everybody knows somebody who has twins, and they've probably done really well, because obstetrics, modern day obstetrics, is has kind of come a long way. But it creates a risk that if we could avoid, we really do wish to avoid it. So we want you to have one healthy baby at a time. So if it was about transferring two embryos from tested embryos, I would say, gosh, I sure don't recommend that you do that. However, since you had a successful pregnancy that unfortunately stopped growing, and then you had an FET that was not successful, in all probability there, Melissa, you could do two embryos and still be within guidelines, because you had that unsuccessful transfer before. So I would say two embryos is okay. What are the odds that they're both going to stick? Well, that really depends on age. That is really a factor based on the age at which those embryos were created. And as far as an HCG wash goes, that's basically, where we're taking pregnancy hormone, the HCG hormone, and we are giving placing a little catheter on a tiny syringe, and placing that little catheter, that little straw, through the cervix, and washing the uterine lining, placing, just a few cc's of that pregnancy hormone inside the uterine cavity. And that can turn up the receptors for pregnancy, and in some people can be associated with an increased chance of pregnancy. Now, the truth is that the data on it is not very strong for the general population. It's considered an add-on, and there are some practices that really stress the HCG wash as something that you should do. It is an extra cost associated with your treatment. So, I don't think it's something that is going to harm you, but the question is it really going to help? In most cases, I would say, the evidence isn't there to say that it helps in most cases. So what's happening there is that, you had an embryo that made it to 6 weeks and 5 days, and then it stopped growing. That is in all probability related to the embryo itself. In most cases where the embryo stops growing, that is a function of the embryo, not of the uterine lining, not of the mom. That is usually a chromosomal or a metabolic issue with the embryo. In the second situation, you didn't get an implantation. which is also almost always a function of the embryo itself. So, do you need to do something extra for the uterine lining? Well, you've already proved that that uterine lining works. You already had an implantation. So, again, it's not something, it doesn't cost thousands of dollars to do. It's something extra to do. It's an add-on, and it's an add-on without proven benefit in the general population. So therefore, I say consider it. It's not a deal breaker to either do it or not do it. It's not something that's going to harm anything. So I think that you can, but I wouldn't say, oh yeah, you should. Does that make sense? Best of luck next week, Melissa. We will all have our fingers crossed for you. By the way, if you're just joining Fertility with Fink at 5:30 or at half past the hour, we do the 5:30 fuzzies with Fink fuzzies, and that's where we all kind of get together and send well wishes out to each person who's on the broadcast and everybody that we're thinking about tonight. So please stay with us if you can till the bottom of the hour. If you have friends who can join us even just a couple of minutes before, the more people we can have on when we send those good wishes out into the universe, the better off I think we all are. Let's see here. Gradle says, I have no fertility coverage. Do you have any tips or hacks to save on IVF meds? And the answer is potentially. So first things first is that you're going to want to use medications that come from the fertility specialty pharmacies. And that is a pharmacy that, for instance, MDR is one pharmacy that really does a great job, and they will match anybody's lowest price. So these fertility pharmacies are they're discount pharmacies. They've negotiated deals on your behalf with some of the manufacturers in order to be able to get those medications at a lower price. Now, they're still expensive, but you may save, 50 to 75% over what you would pay if you were getting them from something like a CVS specialty pharmacy, or even just a CVS or a Walgreens retail pharmacy, because those retail pharmacies can get those meds for you. They can order them, but sometimes at twice the price. So, $2,500 in meds may turn out to be $5,000 or $7,500 in meds if you get it from a regular retail pharmacy. So the first thing is make sure that you're getting them from a specialty pharmacy where that price has been negotiated down for you. There are some other little things that you can do. There are some free market things where folks will sell their used medications, and you can often get those at a significantly discounted rate. Many people, when they're done with their IVF, will donate their medications to the clinic. So you can also ask your clinic if they have any donated meds that they could help you with. Now, I will tell you there, Gradle, sadly, in our society right now, most folks who are going through fertility care are doing it out of their own pockets. It's relatively, I won't say it's rare, but it's certainly the exception, not the rule, when there is fertility coverage for IVF. So other people out there are in that same boat trying to save money on the medications. And so at least that's a couple of places to look. One, ask your clinic if they have extra. Two, make sure you're getting it from a discounted fertility pharmacy, and shop around for prices. Because, again, MDR pharmacy will match anybody's price, but shop around to get the lowest price. So if theirs isn't the lowest, you can say, well, I had an offer from, Dave Jones's pharmacy. I made that name up, and it was a little bit cheaper. And they'll say, okay, well, we'll match the price, and look at those medication marketplaces. Now, technically, it is illegal to resell medications, but sometimes people will donate it, and there are ways around that. So that's what I would say is worth looking into. Rosa, you are getting close to having a baby, my friend, aren't you? 43 years old, uncomplicated IVF pregnancy this far. Is induction at 40 minutes, at 40 weeks, too late. I'm worried about the risk of stillbirth. And yes, the risk of stillbirth does go up as our age goes up. And so I would say, I think you're about 37 weeks now, if I remember correctly. Usually, when I was practicing obstetrics and delivering babies, I would, moms who are of an advanced reproductive age, sort of, certainly in our 40s, after 40s, we would do some extra monitoring. We would look at least a once, but sometimes twice weekly ultrasound, and that's called a biophysical profile. A biophysical profile, or a BPP, is an ultrasound that's done that looks at 4 different criteria. It looks at overall fetal movement. It looks at flexion and extension of the limbs, or, whether an arm or a leg or a foot. It looks for, movement of the joint. It looks for the amniotic fluid index, or for a pocket of fluid that looks normal. And it looks for fetal breathing movement. Now, babies on the inside the uterus, they don't breathe the way we do on the outside, because they're getting their oxygenated, their source of oxygen, it's coming through the umbilical cord. It's coming from mom's blood and passing through the placenta to the baby. But they still do this breathing movement where the diaphragm expands and contracts. They don't breathe constantly, but over the course of 20 minutes, you ought to be able to see at least one episode of that breathing movement. So each of those criteria is assigned points, 2 points for each. You can't get 1 point. It's either 2 points or nothing. And so we do a BPP, which gives you, probably 3 days of reassurance that everything is looking good, that the blood flow that's going through the placenta to the mom is adequate to maintain the baby and in the pregnancy, and that things look safe. So usually we do that twice a week, and you're looking for an 8 out of 8. Now, sometimes some offices will do that a little modified. They may put you on the monitor to look at the baby's heart rate, look at the fetal heart tracing, and do that with just looking at sometimes just the amniotic fluid, the amount of amniotic fluid that you have. And that's called a modified BPP. As long as that continues to be reassuring, and frankly, I would always do that really after 36 weeks, because as we start to approach term, we want to make sure that we're not missing anything. Really, Rosa, by the time you're at 39 weeks, there's no good reason to still be pregnant. But to have an induction of labor between 39 and 40 weeks, or even on your due date, which is the 40th week, is not too late, as long as all the testing leading up to that point is okay and is normal and reassuring. This is a very exciting time as you are approaching delivery. So I hope you have everything ready at home. And I, for one, can't wait to see a picture of your baby. By the way, I will tell you, if I have been involved in any way in helping your family to be born, whether that was retrieving an egg or making an embryo or transferring an embryo, or even just a little consultation, I would love to have a picture. I would love it if you would send me a picture through Instagram, because I would really like to show those pictures off, because the world needs to see more happiness, and that is one way to share it. Let me help share your happiness. If you got a picture, please give it to me so that I can show other people. And let's see, Amber, you had a very exciting week, didn't you? I have to say a big thank you goes out to Amber, who gave me a very cool little gift here. And you know what? I have it just off the side. Let me grab it here because I want to show it off. This is a candle, and it says, Well, you may be seeing it backward there, but it says, look at you turning embryos into miracles and shit. Smell that? It smells like a 100% badass IVF warrior. So, Amber, I don't know where you got that, but I love it. It sits now on my desk, and I have had more comments about it in the last couple of days than I've had comments about anything in a long time. So thank you for that. I appreciate it. Amber says, we have been planning on doing PGT and get to a day 5 blast, and we don't have enough. If we have been planning and we don't have enough eggs to test, can we hop right into a fresh transfer instead, or is there some sort of waiting period? Well, no, you really can't because, probably not. I'd have to look at some things, but usually we would keep you on some extra estrogen for the lining, and we would give you some extra progesterone so that we could prepare that lining for implantation. So that would happen after an egg retrieval and before a fresh embryo transfer. So I would say you're really going to be better off, I think, if you could freeze your embryo and come back and do a frozen embryo transfer next time. When we look at fresh embryo transfers versus frozen embryo transfers, and this is something that we've talked about kind of a lot in this forum, people tend to do better with frozen embryo transfers. And that is often something that people kind of don't have an intuitive understanding of because, you think about, well, fresh vegetables are always better than frozen vegetables. And so why would a fresh embryo should be better than a frozen embryo? Doesn't the freezing an embryo potentially damage it? The success rate of thawing an embryo is about 99%. It's very, very high. But you have to realize that when you've done an egg retrieval and you are making embryos, your body has really been in egg making mode. You have really gone the whole 9 yards to try to make eggs. So that may not always be so consistent with when it comes down to being pregnant. You may be more into egg making mode than getting pregnant mode. Now, there are certainly some situations where that's an absolute. It has to do with your progesterone level. Sometimes people who have hyperstimulation, if the estrogen level was greater than 3,000 at the time of retrieval, then we would say, you know what, that's really not a good place for a fresh embryo transfer because the uterus is not so hospitable. The body has really been trying to make eggs more than it is ready to be pregnant. And people feel compelled to have to do it. They get, kind of married to this idea that they want to have their fresh transfer, even though we're telling them that odds are really against you in that scenario. But all other things being equal, we do fresh transfers here. In your situation, Amber, I would say, we would have started some medication just to make sure that everything would line up so that you could do it. So let's just plan that you get a bunch of blasts to be able to PGT test. I think that's a much better idea. Let's stick with the original plan. And thank you again for the candle. Hi, Angela. Nice to see you this evening. Marlena says, I have a question about DHEA supplements. I know you say diminished ovarian reserve. Is that for patients with an AMH of less than 1? And the answer is yes. So, there is an evidence-based protocol for what can a handful of vitamins do for us to help get us pregnant. And so much so that I wrote a book on that. It's called The Vitamin Victory. It's an easy little $7 ebook that includes a coupon code that gets you probably $40 in discounts on those very supplements if you want. That link is on my Instagram, Randy Fink MD, on the link tree there. So just click on the little link under my name and it'll show you where you can pick up that book if you want. But the DHEA, yes, 100% is recommended for people who have a lower ovarian reserve, and generally speaking, and by that I mean less than 1, and generally in women who are over the age of 40. The recommendation for DHEA is 25 milligrams 3 times a day, except for the scenario where if you have polycystic ovarian syndrome, then usually we don't recommend DHEA. And why is that? DHEA is a hormone that is part of the hormonal cascade that ultimately makes testosterone. Now, what's the significance of the testosterone? Well, it's pretty easy. Testosterone is metabolized into either testosterone, the active form of testosterone, or into estrogen. And estrogen, as you know, is the language that your ovaries speak. And so a little extra estrogen is a good thing for egg quality. And so that's where DHEA comes into play in those with a lower ovarian reserve. So yes, less than AMH of less than 1 or age greater than 40, I generally recommend 25 milligrams 3 times a day. Hello to, looks like OU Denver. Hello there. Blaxican Beauty, hello, my friend. Good to see you. We've got Little Oak, Andre. Nice to see you. The wonderful and talented Jody Hoffman appears to have joined, or at least she did for a moment. Jody, you may know, was a former nurse manager when I worked in Colorado, and is a wonderful soul, a great spirit, and has a couple of beautiful dogs. And a very nice cat as well, Opie. So please tell them all hello from me. Hi, Jody. Noodles for Life says, positive BCL6, do I go straight to start suppression any day during the cycle, or do I need to wait till cycle day 1? Is there a preferred suppression medication? All right, so if you aren't aware, BCL6 is the marker for endometriosis. It used to be that the only way we could diagnose endometriosis was by surgery, by doing a laparoscopy to look around. The problem is that when you do surgery, first of all, it's surgery, so you need general anesthesia and you're putting sharp implements into your abdomen. But the thing about endometriosis is that what you see is not always what you get. In fact, what you see is really just the tip of the iceberg. So when it comes to endo, if I see this much endometriosis and try to treat it, odds are there's way more endometriosis there. So I really do think that medical suppression is a better idea for treatment than is the surgical treatment, unless you have really terrible periods. If you have a lot of pain, then there may be some benefit to having a laparoscopy. But what I would say is the non-invasive way to diagnose is through the endometrial biopsy done at a particular time during your cycle that checks for the marker known as BCL6. I recommend the medical suppression. You can use Lupron, you can use Orilissa, or you can use Myfembree, and they are all said to be equal in their outcomes. So whichever is easier. Now, Lupron is the older way of doing it, and Lupron was all we had for 30 plus years. Now we have some newer drugs, the pill that you can take, and that's Orilissa or Myfembree. Those, I think, are a little kinder, gentler way of doing it. They have a little lower side effect profile, and the side effects are that it puts you into really a temporary menopause. Lupron pulls the plug on all your hormones, and hormones are gone, and then voila, that takes away the food source, if you will, of endometriosis. So I think you can use either one. You can really start at any time. So if you start your suppression at a random time during your cycle, you are just more likely to have irregular bleeding during that cycle. If you start on your cycle day 1, then you might have a little a bleed after you've started it, but in all probability, you're not going to get another period until you stop it. If you're starting in the middle of the cycle, you just may get some irregular bleeding. And since we're talking about suppressing that only for 60 days, because 60 days is what's associated with improving the odds, really returning your odds of embryo transfer back to normal, that's all I would do. I don't really feel like you need to do more, certainly not at least for fertility's sake. A special hello here to Little Oak 87, former patient of yours from Colorado. You did my egg retrieval. I am pregnant from my second FET, 15 weeks. That makes me so happy. I love hearing that. Thank you so much for sharing and for being here tonight and saying hello. God bless you, and fingers crossed. So it's time for the 5:30 Fuzzies with Fink. And if you haven't seen this segment of the program before, the point here is that we're all here for our own reasons. Some people watch this for entertainment. Some people watch it for the spiritual awakening it gives to know that other people are going through the same trials and tribulations. Many come here for information. Many come here just knowing that it's the right place to be. And whatever your reason is, I want to take a moment for us all to stand together as one community with if we could put our arms around each other, I would say, let's do that. Let's hold hands virtually. Let's all get together and really send our thoughts out to each and every person who is on the broadcast who needs our help. Whether that is a fertility thing, whether it's a work thing or a relationship thing, a family thing, a health-related thing. For all of you out there who need to know someone else is thinking of you and someone else is truly, sincerely in their heart wishing you well, this is going out to OU Denver and to Sheila 125, Little Oak to you especially, Bell Nashi, Blaxican Beauty, Nurtured Shanna, Lexi for you for sure, Sharmilla, Golf DPT, AZ Signatures, Rosa for you, Amber, 100%, Tiana, if you're actually on there, you too, Jody Hoffman, oh, look who's here. Jody from CNY in Sarasota, to Angela, to Shabnam, to Kowser, Dancer, Faith, Hope, and all those folks here at the beginning, to Gradle, to Lamu Hair, Plant Honeys, Rice Ninja, Noodles, if I didn't already say that, Melissa for you, Marlena, Daisy, to Savannah, the Stiles family, to my Bama gal and her beautiful husband, Harold. Let us all say, mwah, we got this, friends. We can do this. This community is here for you. We are all thinking about you. Positive vibes to everybody out there. And that, my friends, is the 5:30 Fuzzies with Fink. Please ask your friends to join next week. The more people we can have to send out those positive vibes, if you can just take a moment, close your eyes, and send your goodwill out in the universe, I think it's really making a difference. So thank you guys all very much for being a part of that. Okay, let's jump back into our questions here. Gosh, Little Oak, I am so flattered. Thank you very, very much there. Blaxican Beauty says, I just had my FET on Friday the 17th, praying that they stick. You and me both, friend. Man, it's a hard time, isn't it? That waiting period until you get it. It's a hard time until you do that. Until you do that pregnancy test. But yes, absolutely, fingers crossed. Lexi, I see that you are on here, and I want to see if you said something because, oh, you love the candle too. I'm waiting to hear about your ultrasound because last week you were about 5 weeks or so. And we're waiting to see what happens in your ultrasound. Please let us know. Angela asked, is it okay to use Follistim and Gonal in the same cycle in case you run out of one? The answer to that is yes. So Follistim and Gonal-F are really essentially the same medication. They are what's called recombinant FSH. So it's a chemically manufactured follicle stimulating hormone. They are just two different manufacturers. One is made by the company Ferring and the other is made by Organon. The device, the injection is a little bit different. That is to say that you may have a single dose. You may have a bunch of single dose vials. You may have a multi-dose vial, or you may have a pen where you can dial in your dose. But the medication itself is the same. So yes, I would consider them interchangeable. Follistim and Gonal-f. What is not interchangeable is Menopur. Menopur requires a little dose adjustment on your other medication, so not quite the same thing there. So let's see here. I do want to, Jody, if you are still on there, a very special hello to you. Those of you who are using CNY Fertility may know there is an office in Sarasota, and the embryologist at that location, her name is the chief embryologist. Her name is Jody, and she is a wonderful person, a great scientist, a great soul. And I'm very honored to know that you would pass by here. I'm honored to have you as a friend. Thank you for being here. And if you end up going to Sarasota, ask to say hello to Jody because she's got the good vibes for sure. Okay, let's see. Lexi loves the candle. Good deal. Can I get pregnant with an AMH of less than 1? AZ Signatures ask. And the answer is absolutely that you can. So the AMH is not a measure of can you get pregnant or not. AMH is really designed to be able to show us and to predict for us how your ovaries will respond to medication. And that's really all it is. It's a reflection of the ovarian reserve. So, you are born with all the eggs that you'll ever have. And over the course of our lives, we start to lose these eggs. Well, we can't actually measure the eggs because even when the count is very low, there's still thousands to hundreds of thousands to maybe even millions. And they're microscopic, so you can't count them by ultrasound. But every one of the little eggs in the ovaries is surrounded by some cells. And these cells secrete a hormone that's called AMH. AMH is anti-Mullerian hormone. So the more eggs you have, the more those cells you have. And the more those cells you have, the more AMH you make. And so we can measure that amount of AMH in your blood and plot it out on a little graph to see where you are relative to other people your age. And that shows us, because the ovaries tend to age at a rate that is a little bit faster than the rest of the body. And so it's a very common thing to find. I see that, really every single day in my practice. I do think it's important to know what your AMH is. If you just happen to be passing by here tonight and you're curious, you should know your AMH. It's your ovarian reserve. It's a question about your fertility. It's an easy blood test to get. So go get it if you haven't already had it. But what it tells us is how you're going to respond to medication. It doesn't say anything at all about your ability to get a sperm together with eggs. So can you get pregnant with an AMH less than 1? Oh, yes, you certainly can. And all by yourself. You don't even need extra help. Sometimes it absolutely can happen on its own. Not a reflection of fertility, but rather a reflection of how is your body going to respond to fertility medication. That's what that's all about. Faith, Hope, Love, Warrior, Fertility says 7 days post a day 3 embryo transfer. I've had cramps on and off since yesterday, some nausea on and off. I'm tired. Is it the medication? Is it PMS or failure? Is it early pregnancy or implantation? I'm doing HCG booster injections, progesterone, and estrogen since the FET. So I would say, certainly the medications probably have a lot to do with that. Natural progesterone has a sedative effect. And so it may be kind of really just slowing you down. The crampy, I think, is kind of par for the course. Nausea, estrogen, can make you nauseated. So I would say sounds like pretty normal stuff there. And absolutely our fingers are crossed for you in about another week when it's time for you to get your beta. Let's plan on it being positive. And speaking of being positive, yes, I don't think there's anything about what you're describing that is unusual or that portends anything bad. It's kind of all a part of this FET process. Hello, Mrs. V. Nice to see you. And Erica Alyssa. Shada, hi, how are you? I miss you as well. Okay, so Lexi, I asked you about your ultrasound there, and I won't have one until Friday, but we'll let you know next Tuesday. The 5:30 Fuzzies helps to keep my spirits up. A special thank you to Jen Hardwick over here on the Facebook side who says, yeah, we got this, friends. What a great community this is. And that's exactly why I do this 5:30 Fuzzy things, because this is a community. It's not a bunch of individual strangers that are coming, together. These, I think every person who watches my podcast here would really probably do anything to help somebody else if they were in need, to answer a question, to share in their own experience. So, gosh, if we could send a little extra positive energy out into the universe, that's a very powerful thing. And it's something I think we ought to be doing every single day. Hi, Kelly. Zenny from Miami is here. Good evening. Thank you for being here. I happened to see a picture that Zenny posted of, I think it was an AI thing of what would happen when she turned 75. And those things are cool. Very impressive, Miss Zenny, very impressive. Hi, Sarah. The Meg Johnson. Hello, good evening. And Minji56, haven't seen you for a little while. Hi to Wendy. And Shada is there as well. So, I wanted to say a little bit of something about people having different experiences in different clinics. Without naming names or pointing fingers at any particular place, no matter where you go, your experiences, especially with something as personal and as sensitive as fertility, experiences will always be variable. It would be very unusual to run across a place where somebody didn't have hard feelings about something, especially when you're paying a lot of money for these services. You have high expectations, but different places offer different types of services. And when you're often speaking to a different person and maybe getting a different answer than what you got the first time, and maybe not feeling like there is someone who is following your care from point A to B to C to D and all the way down the line, can be a very frustrating experience. When we're dealing with these kinds of frustration in the fertility world, I think it's very important that you advocate for yourself. Now, again, I can't think of any institution or any system in the practice of medicine, no matter how boutique the practice is, no matter how much they charge, even the places that charge $30,000 and $40,000 for a single cycle of IVF. There's not a one of them where there isn't some feeling of lacking a personal touch, or of somebody who just doesn't have it in them that day, who makes you feel bad, or who you feel didn't treat you right, or asks for money when it's really a bad time and you feel that that's really insensitive. There's always going to be something, and there's always going to be someone, because the world is filled with someones. And I think by and large in fertility, folks who go into this particular area of healthcare, really want the best for other people. But you just there's no way to have a perfect system. People want you to succeed, but it is frustrating when you have this kind of variability and you don't see things going exactly the way you want. You know what I mean? That's just my 2 cents worth there. Okay, thank you for allowing me to share. Sarah asks, my 5AA euploid girl had a starting beta of 36, and we made it to a heartbeat, but then right before 10 weeks, I found out the heartbeat had stopped. Was the low starting beta a big red flag? And I would say, well, first of all, I'm so sorry for your loss there, because that is really cruel and unusual. Because you had a situation where you had a very, very excellent graded embryo, 5AA, and it was a euploid embryo. So we know that that embryo, or at least believe that that embryo was chromosomally normal. Yes, unfortunately, those embryos can still sometimes miscarry. Why does that happen? Well, it can really be for a couple of reasons. One is, most commonly, well, we believe that the chromosomes are normal, but we can't say anything about the millions of little chemical processes that are happening in an embryo at any given moment. And if one of those falls astray, then the embryo can stop growing. Furthermore, there are limitations to the whole PGTA testing. And that is that we're testing the embryo from the portion of the embryo that becomes the placenta. And we're not testing from the baby itself. And there can be some discrepancy between what's going on in the placenta versus what's happening in the baby itself. PGTA is not perfect. And so these are a couple of reasons. There can be maternal reasons, but more often than not, it really is an embryo problem. So the number from that beta HCG really has to do with the timing of when it was drawn. So certainly if you were 16 days after an embryo transfer and you had a beta of 36, I'd say something is not right about that, because it should be much higher. If you were 10 days past a day 5 embryo transfer, or 8 days, then I would say 36, might not be unusual, because we're assuming that the embryo, implants right away, but sometimes it may hang out. It may be 72 hours before that embryo actually makes its way to implant and start producing that HCG. So no, I don't think so. I don't think that the lower than normal HCG is a red flag of anything. Now, the one thing I would say there is that there are some practices in particularly in natural cycles that routinely use what are known as HCG boosters. HCG boosters is where you get a little extra of the HCG hormone. And that functions as LH in your body and basically makes more progesterone. And progesterone is the hormone that maintains your pregnancy. If you've done a medicated cycle and you're getting, let's say, progesterone and oil, we're giving you a ton of progesterone. So an HCG booster, there's no evidence that it helps in that scenario. If you've done a natural cycle or a modified natural, then an HCG booster can help. But recognize that when you do your HCG, your beta, you'll find that, well, you're testing your blood, the stuff that you injected into your belly that morning. What do you think the blood test is going to show? Yes, absolutely. It's going to be positive. So if you do that HCG booster, I always warn people, be cautious. Understand that your first beta is going to be positive. Really, the important thing is, well, what happens with the second beta? What happens 48 hours later when we check it again? Because if you're still doing the HCG booster, you're going to have a steady level of HCG, but your pregnancy is making it as well. So your level will be going up. So that's the only scenario where I'm particularly cautious about those low betas. I have a special guest who is walking into the studio as we speak, and this is
hello.
Elise,
I'm
the embryologist. Do you know Elise? She has joined me before on the program.
Yes, it's been fun. I figured I'd stop in and say hello before I headed out.
And she literally just flew in. You see, her wings are tired.
I know.
Just flew in. Elise has been back in the lab today. She's here for our cycle. We're doing transfer. We did retrievals last week and transfers today. Biopsies and all manner of things, except that I think for a short period, the air conditioner in the lab.
It was hot. It was hot in there.
Yeah, there's a lot of equipment and a lot of hot breathing people back in there. So I'm so glad that you are here. It's wonderful.
I just wanted to pop in and say hello to everyone.
That's the lady right there. And if you don't follow her, you should. That's Alease, the embryologist. Elise, thank you. See you tomorrow. She's here for another day. Well, what a special event that Elise stopped by here. We love her around this place. Well, we've got a few more minutes here. If you've got other thoughts and questions, please throw them my way. By the way, if we can't get to a question or if you don't feel comfortable asking it in the open environment here, please feel free to email me. And that is askfertilitywithfink@firstfertility.com. I have come to be aware that some of the questions that were going there were going to the spam folder, and I just found a couple of them today from a couple weeks ago that I missed, and so I answered those emails back. Hopefully it's not too late to still help you here. And also don't forget, every Friday is Ask the Doc Friday on my Instagram, and that's Randy Fink MD. Please follow me. It's a chance for you to ask questions and for me to put up pictures that I've taken during the week, things that I think are pretty and hopefully are motivating to you. Let's see. Mrs. V says hi. Macy B says, thoughts on SERs and their impact on fertilization. SERs. I'm not sure what that means, Macy. Help me out there and tell me what an SER is. And I'm sure I have thoughts on it. I'm not sure about the abbreviation. SB Charles, good to see you here this evening as well, along with Veronica. And let's see what else we got going on here. We say hi to Carly. And, in the coming week, I would ask you, does she mean serovital? Serovital is, so serovital, if that was the question, I'm going to get back to my thought there about the coming week, but I don't know if you are still there, Macy B, please answer us. What do you mean about SERs? But serovital is a supplement that that is said to increase your growth hormone levels. However, it hasn't been well studied in pregnancy, and there are some ingredients in serovital that have actually been shown to diminish egg quality. Now, I don't know if the overall effect of all of serovital potentially increasing growth hormone is whether that outweighs the negative effect of that one particular ingredient. And if I am remembering correctly, the ingredient I think is L-arginine, which is something that we absolutely use for embryo transfer because it increases blood flow, but I believe it's associated with lower egg quality when used for stimulation. So I don't recommend serovital. Where I used to work, there was a doctor there who routinely recommended serovital to everyone. I recommend it to no one for fertility because I think it may actually be harmful. Smooth endoplasmic reticulum. Oh, okay. So the question was thoughts on smooth endoplasmic reticulum and their impact on fertilization. Well, yes. So the endoplasmic, and that's Macy from MCRM. I didn't know it was that Macy. Well, let me just tell you about this Macy. So if you have ever had, I do get to do some work at Missouri Center for Reproductive Medicine. I go there once a month and help out with embryo transfers. And I have to say that is one of the finest groups of people I've encountered. The doctors, the staff, the nurses, the embryologist, the whole team there is just really top notch. And it is truly an honor to be able to be a part of folks' journey up there at MCRM. Macy is one of those people who is truly exceptional. She is a wonderful nurse. She is a great human being, and is really one of my favorite people. So if you are in that Missouri area and you make some connection with Macy, please give her a special nod, because she's a very special person. Macy, thank you for being here. And you asked me a question that I don't really know the answer to, but I'll tell you what I think. The endoplasmic reticulum is a portion of the cell, and it's a portion that's associated with creating energy within the cell. And as our cells age, the endoplasmic reticulum is one of the first things, along with things like telomeres and some other functions in the mitochondria, that start to decay. So yes, I think diminished endoplasmic reticular function is definitely associated with lower performing eggs. That's one of the things that can lead to an egg not fertilizing, or fertilizing and an embryo not growing, is weakness in those components of the cell. And I hope that's what you were asking, because if not, I just answered a question that you didn't ask. But you know what? Thank you for being here anyway, because you're still exceptional. You're the bomb. Hey, Beach Mom and Amber and Bryn, nice to see you here. Veronica says, any thoughts on how to increase egg maturity rate at retrieval? I have a good number of follicles and retrieve, but only about 30% mature. So that may have to do with the timing of your trigger. And so we know that folks who are a little bit older, that is to say older than, let's say, roughly about 38, but certainly in our 40s, we tend to want to trigger a little bit earlier. And that might be with an average follicle size of about 16 millimeters. Otherwise, I think of about 17, 18 millimeters as what I consider mature size. And what I look for in terms of time to trigger is when more than 50% of the larger follicles, that means the ones greater than about 10 millimeters, more than 50% of them are of that mature size. So it makes me wonder if, what I would suggest is that, you would hold off a little bit longer next time, because in all probability, number of mature eggs really generally has to do with timing of trigger. Now, there can be an inherent egg issue where you're just not making really mature eggs. And one scenario, one scenario where that happens is in polycystic ovarian syndrome. You've got a lot of eggs hanging out in the ovaries, and those eggs may not mature at the same rate. And because they're kind of fighting with each other, you may run into a situation where you have fewer mature eggs at the time of egg retrieval. Okay, well, she said I answered it, so there you go. Pat on the back to you, Macy. Thank you. Hey, folks, we're at top of the hour, which means we are all out of time for this week. Thank you so much for being here. We're here every Tuesday at 5 o'clock Central Time, which means 4 in the mountains, 3 on the west, and 6 o'clock on the East Coast. This is not the book of your life. This is just a chapter. And what are we here to do? We are here to rewrite that chapter together. And every day forward with love, every day forward with kindness to other people. We have said the world is not a kind enough place. Do some random act of kindness for other people. Show up here next week at 1:30 for the 5:30 Fuzzies with Fink, and share some of your love every step forward with kindness, and every step forward with hope, knowing that tomorrow is a new day full of all new adventures. So until next week, I'm Dr. Randy Fink in Pensacola, Florida. Thanks for being here. Good night.